Andrew Wakefield's medical license was revoked to protect the public from his unethical experiments, charged with falsifying data, harming participants, and fraud. Our film intends to make the same case for Dr. Anthony Fauci.
And if you vaccinate someone who's not infected and you have an effective vaccine, when they get exposed, they won't be infected.
But the ones that you absolutely are not going to convince, you need to put some pressure on.
Many of us use fetal tissues for cell lines.
But also there will be a surprise outbreak. Needing to learn from people that I never thought I would be learning things from, namely bioweaponers.
The next pandemic, and there will be one, there will absolutely be an outbreak of another pandemic.
Additionally, under judgment, the vaccine platform mRNA, the origins of COVID-19, the concept of gene editing, and the spike protein.
And you're all familiar with the DNA vaccine, probably going to be replaced by mRNA soon, but
by using the power of DNA, recombinant DNA technology, you could talk about the development of vaccine.
Does the vaccine make you worse? And there are diseases in which you vaccinate someone, they get infected with what you're trying to protect them with, and you actually enhance the infection.
I wanted to pick out the one cell that if I damage that cell, I would do the most damage to the immune system. I, as an immunologist, would pick out the T4 cell.
That retroviruses in a more attenuated form are the major vehicles for gene therapy. So it really is gene therapy. Unfortunately, it's destruction and not therapy.
In the topic for today, which is gain-of-function research on highly pathogenic avian influenza H5N1.
The trial of Anthony Fauci, July 4th, 2023.
The idea came from a physician scientist in the UK years ago who did a study saying that there was a connection between the measles vaccine and autism. And as it turned out, not only was the data incorrect, it was fabricated and false. And for that, that person has been disbarred from practicing medicine. Welcome, ladies and gentlemen. You're about to see a story of murder, greed, corruption, violence, exploitation, adultery, and treachery. All the things we hold near and dear to our heart. And then the show starts.
Ladies and gentlemen in the jury of the Court of Public Opinion, we, the prosecution, stand before you today representing the people of the state in a criminal matter against the defendant in the trial of Anthony Fauci. The matter before us today concerns acts of misconduct across the entire career of Anthony Fauci as a public health official for the United States government. We will show, by producing documentary evidence, that the defendant is guilty as charged of the following: inciting fear in the public to raise funds for the NIH, overseeing unethical experimental research with manipulated data, improper relationships with regulators in the pharmaceutical industry, favoring toxic drugs over safer alternatives, purposefully developing obsolete therapeutics for a rapidly mutating virus, mandating medical apartheid, committing perjury, funding dangerous gene editing experiments.
Fauci is the director of the National Institute of Allergies and Infectious Diseases and is the commanding officer in the nation's scientific war against AIDS.
When a man of Dr. Fauci's stature says they need more, we're going to listen.
And Tony is kind of the last word in medicine. Have you asked Tony? Because if you haven't asked Tony, you haven't asked the top. And if you have asked it, you got the right answer.
I want to tip my hat to the FDA. They have worked with us right from the very beginning. I have never been muzzled, ever, and I've been doing this since the administration of Ronald Reagan. I'm not being muzzled by this administration.
With a career spanning across 7 presidents, let the jury rest assured that the accused is the most appropriate person to stand trial today. At the conclusion of this trial, we are confident that you will find the defendant guilty of the charges for which he is accused in the court of public opinion. To understand the scope of Fauci's alleged crimes, one must review the history of the science utilized during his tenure. Investigations of the history of gene editing reveal the true genesis of HIV and AIDS. Scientists playing God by manipulating viruses. 1966, molecular biologists warned of the potential dangers of gene editing. Retroviruses, viruses that cause cancer, are vital in the process of gene editing. Reverse transcriptase is a retrovirus enzyme that copies the host DNA, giving retroviruses the ability to change the host DNA and adapt its own genetics to the host. Gene editing is a scientific attempt to control the most dangerous viruses known to mankind. The optimists of molecular biology promised that gene editing would provide knowledge of the human genome that would remedy genetic mishaps. In an honest examination, molecular biologists described the prospects of gene editing as terrifying because gene editing could be used as a subtle means of homicide. Molecular biologists admitted gene editing led to only two possible outcomes: destructive transformation or death, with a final warning about gene editing. There are dangers in knowing what should not be known. In other words, do not open Pandora's box. In 1970, the United States attempted to open that Pandora's box. The Department of Defense was allocated $10 million to produce a synthetic biological agent that could destroy the immune system with no possible natural immunity. 1972, the World Health Organization bulletin directed scientists to study animal viruses in humans to determine their effects on the immune system. Seeking out animal viruses such as retroviruses and hepatitis that selectively depress the immune system, particularly the T cell, with the goal of prolonging disease in humans. Using human subjects as guinea pigs and studying viruses was supported scientifically in 1971. Animal retroviruses were found to adapt to their human hosts, transform human cells, replicate themselves, and integrate themselves into the host DNA. Retroviruses mutate quicker than any virus, approximately 1% per year. The original animal retrovirus studied in humans was SV40, a cancer-causing simian retrovirus contaminating all polio vaccines until 1964. This retrovirus, SV40, was used to successfully edit the first genes in 1972, spawning the birth of gene editing and recombinant DNA. Pandora's box had been opened. Further study of how retroviruses jump species from one mammalian host to another led to the discovery of the first immune system depressing factor that specifically inhibited T cells. 4 years after the 1972 request from the WHO to find retroviruses that could inhibit T-cell function, mass vaccination campaigns of the 50s, 60s, and 70s led to the study of animal retroviruses in humans, repeating the mistake of the polio vaccine contaminated with monkey retrovirus SV40. The smallpox vaccine used in campaigns across the world were contaminated with various cattle retroviruses. Cow retroviruses, bovine syncytial virus, and bovine leukemia virus were found in apparently healthy cattle across the world. The smallpox vaccine, made directly from cattle, was contaminated by these viruses. Retroviruses, bovine leukemia virus, and a sheep Visna virus adapted to each other through recombination inside cattle hosts to create bovine Visna virus. In 1978, bovine Visna virus adapted to human tissue, giving it the ability to infect humans. Bovine Visna virus, a cancerous retrovirus with the ability to prolong disease, fit all the requirements of the 1972 and 1970 requests. Bovine Visna virus was found to be a common contaminant of fetal calf serum in laboratories worldwide. Fetal calf serum is a vital ingredient for vaccine production, including the smallpox vaccines and the hepatitis B vaccine. The 1978 and 1980 hepatitis B vaccine trial participants were exclusively homosexual men from New York City, San Francisco, and Los Angeles. Retrospective studies of the hepatitis B vaccine trial showed that 11 of the first 24 AIDS cases were participants in these trials. By 1983, 62% of the participants had developed AIDS. In 1987, the World Health Organization contracted with an epidemiologist to research the correlation between the WHO smallpox vaccination campaigns and the AIDS epidemic in Africa. The epidemiologist found a direct correlation. The WHO smallpox vaccination sites correlate with HIV epidemic spread. and a 19-year-old Army recruit was admitted to have developed AIDS after smallpox vaccination. Other researchers feared supporting this theory not because of the facts, but fear that it would be seen as criticism of the WHO. Bovine visnovirus, a disease so strikingly similar to HIV that it was renamed BIV, bovine immunodeficiency virus, whereas simian immunodeficiency virus, which to this day is said to be the source of HIV, is unrelated to HIV, and this is corroborated by the fact that monkeys infected with HIV do not contract the illness. Bovine visnovirus was predicted to have the same outcomes of the HIV pandemic in 1978. Bovine visnovirus may play a role in either malignant or slow virus disease in man. Exposure of genetically predisposed individuals may result in apparent or latent infections. After analyzing HIV's core proteins and glycoprotein envelope, it was determined that the virus could not have originated from nature and most likely occurred from vaccine contamination with retroviruses. The origins of HIV and AIDS are not from the jungles of Africa or homosexual behavior. The origins of HIV and AIDS are from retrovirus-contaminated vaccine programs. Smallpox vaccine contamination led to HIV in America, and the hepatitis B vaccine trials led to HIV in America. There is evidence that the defendant, Mr. Fauci, was aware of this information while overseeing AIDS research for the NIH.
1, 2, 3 testing. 1, 2, 3, 1, 2, 3.
It's Dr. Anthony Fauci with the National Institutes of Health. Dr. Fauci, given Dr. Oleski's work, do you see any direction, any turn that has been made in this disease, given especially Oleski's work?
When you have a situation that we're seeing here with this recent article by Oleski, in which children, household contacts of either individuals with AIDS or individuals at high risk for AIDS, have indeed a syndrome that's identical to AIDS syndrome, that tells you that it's quite possible that just intimate contact outside of the sexual contact blood transmission route is a possible mechanism whereby this disease can be transmitted. If that's the case, then indeed the implications for the spread to even other groups besides infants and children become something that needs to be reckoned with. So I think it is going to have a major impact on our thinking about what the real confines of the syndrome will be.
Fauci incited a national panic by validating the Oleski paper, stating AIDS could be spread by casual contact to children. Fauci repeated this claim in print, scientific publications, and television. As a public health official, Fauci understood that evoking fear would increase his power and resources as the overseer of AIDS research for the NIH.
The cause of AIDS is unknown, so is how it is transmitted. These facts add up to an officially declared medical epidemic. They have also, according to Margaret Heckler, Secretary of Health and Human Services, spawned a second psychological epidemic, one of fear of catching AIDS. Both epidemics have been widely reported in the last few weeks, as any regular newspaper reader and television viewer know.
Fear of AIDS has been building for months in the gay community, but it was a report in a medical journal in early May about some of the affected children that helped spread the fear among the general public. The report suggested that AIDS could be spread to family members through casual contact, a conclusion disputed by many doctors. Still, it's been charged that the fear has spread faster than the disease.
Paramedics, worried about being infected by AIDS, take what they believe are reasonable precautions. They're fearful because so little is known about how the disease is transmitted.
They burned everything this man owned because they were afraid that just by touching it, that they could come down with AIDS.
There's absolutely no evidence whatever that you can get AIDS from a risk group patient, such as a male homosexual or an IV drug user, by the usual everyday contact that you have with an individual. So that's an unfounded fear, we believe.
Researchers on both sides of the Atlantic say they are ready to announce they now have strong evidence that a cancer virus is the cause of the deadly disease AIDS, acquired immune deficiency syndrome. Still, the researchers cautioned that further work is needed to confirm absolutely that the virus is the cause of AIDS and not just another one of the many bugs that take advantage of victims' weakened immune systems.
The probable cause of AIDS has been found, a variant of a known human cancer virus called HTLV-3. Second, not only has the agent been identified, but a new process has been developed to mass-produce this virus. With discovery of both the virus and this new process, we now have a blood test for AIDS which we hope can be widely available within about 6 months. We've applied for the patent on this process today. Thus, we should be able to ensure that blood for transfusions is free from AIDS. We hope to have such a vaccine ready for testing in approximately 2 years.
What about why is it going to take 2 years to get a vaccine?
Well, in the first place, we have to isolate some portion of the virus. We think by a process known as recombinant DNA, doesn't make much difference what the name is, but that's the name of it, that we will be able to produce a portion of the virus that will stimulate the production of antibodies without causing the disease. I think what we've shown is that retroviruses can cause serious illnesses in people, but the implications of this, I think, will open up new areas of research.
Today we're going to be listening to Dr. Anthony Fauci. He's going to be talking about AIDS.
When I first read in the report from the CDC of these cases of strange infections and tumors in male homosexuals in the New York City area and in California, LA, and San Francisco, how this disease, which we surmised early on, started off in the male homosexual population in this country. It's straightforward epidemiology. You take an infectious agent and you introduce it into a population in which the spread among those individuals, if it's sexual contact spread, it's a perfect setup to spread. Now, I suggested the hypothesis to you that the disease started off in this country within the male homosexual population. And that's exactly what happened. There are some theories of how it got introduced into the male homosexual population. If that is the case, which indeed it is, then the transmissibility will relate to the contacts within the male homosexual population, as well as the overlap between the male homosexual population and other populations that became risk groups. And now that's very clearly seen. Now, you keep getting asked, why the male homosexual population? Well, as I mentioned, for reasons that will become clear shortly, the virus was introduced into the population from the homosexual group to the needles of IV drug users. Hence, you now have it in IV drug users who spread it among themselves by sharing the needle, which is contaminated by this virus. Clearly, we have documented a significant number of cases of transfusion-related AIDS. In essence, AIDS is a difficult disease to catch. It definitely is a difficult disease to catch. We know how it's transmitted, but you can be exposed to that agent and not at all get the disease. Now, what about the geographic origin of AIDS? The scientific data is that AIDS exists in Africa, in Central Africa, particularly in Zaire. It exists in a rather substantial way. The incidence of AIDS in Zaire is as great as it is per 100,000 population as it is in San Francisco. We know that the disease existed there in the early 70s, before it existed in the United States. This T cell, it's called T because it's derived from the thymus gland, helper cell, responsible for helping not only this B cell, but all other cells perform their function. It's the catalyst that makes the immune system go. It's the focal cell that orchestrates the immune system. We have suppressor cells, which can actually dampen down the immune system. So we have B cells making the antibodies, T cell doing the orchestration, suppressor cells keeping the lid on things so that the immune system doesn't run away with itself. When it does, as a matter of fact, that's how you get autoimmune disease. How does HTLV3 affect these human T cells? Well, it selectively infects the T cell. It has what we call a tropism for it. If you put a lot of cells in a tube and you throw in HTLV3, it'll go right for that T4 cell and infect it. It has an affinity for the helper cell. It seems to leave the suppressor cell alone. This T4 cell, as I alluded to earlier, is the critical cell. What it does is that it's responsible in a direct or indirect way for virtually everything the immune system does. I wanted to pick out the one cell that if I damage that cell, I would do the most damage to the immune system. I, as an immunologist, would pick out the T4 cell. That's exactly what this virus did. It picked out the T4 cell. In essence, AIDS is a difficult disease to catch.
How is HIV most efficiently transmitted, Mr. Fauci?
By sharing the needle, which is contaminated by this virus.
Contaminated injections. Then how did HIV emerge at first only in the homosexual male populations of the United States?
Why the male homosexual population? For reasons that will become clear shortly, the virus was introduced into the population. That the disease started off in this country within the male homosexual population. And that's exactly what happened. There are some theories of how it got introduced into the male homosexual population.
According to you, Mr. Fauci, AIDS is a difficult disease to catch unless you receive a contaminated injection. AIDS only emerged in very specific populations of homosexual men from New York, Los Angeles, and San Francisco during 1978 to 1980. Since there are contaminated vaccine trials that correspond with the date and population of HIV's origins, would this be the introduction of HIV in America?
It's straightforward epidemiology. You take an infectious agent and you introduce it into a population.
Why would the WHO and the Department of Defense want to develop a virus that selectively inhibits the T cell if they had a joint goal of prolonging disease in humans?
You have one cell that's infected specifically with a virus that has a given function, and yet when you look at the immune system, it is globally wiped out. That those different cells are critically dependent upon that one cell that's the victim of the virus.
No further questions at this time, Your Honor.
The test does not, however, show whether a person has or ever will have AIDS. While the test only indicates a potential for contracting AIDS, many fear it may be misconstrued as a diagnosis of AIDS. Diagnosis, which in many cases has cost people their homes, their friends, and their jobs.
How accurate is the test?
We don't know yet, but this whole question of false positives and false negatives has plagued medicine for centuries.
Last week, a school board in the Queens area of New York said it would prohibit children with AIDS from attending school. 7th grader Ryan White of Kokomo, Indiana, is a hemophiliac. Last December, he got the AIDS diagnosis. Now he has to attend school from the other side of a telephone.
We're not talking about discriminating against gays. We are talking about discriminating against someone with an infectious disease.
In just 4 years, the federal research money for AIDS in this country has multiplied from $5.5 million in 1982 to $109 million this year, and it's expected to double to $200 million next year.
Now, when you take a sexually transmitted virus and you introduce it into a population in which there is a lot of sexual interaction among the group, you will see, as a result, spread of that agent within that risk group. And unfortunately, that's exactly what happened with the male homosexual population. Somehow, the virus got introduced into that population, and that virus happens to be a sexually transmitted virus. But it isn't intrinsically related to the concept of homosexuality.
Why, then, is it not spreading as rapidly in brothels among the promiscuous heterosexuals?
Because the disease hasn't been introduced in the sense of being interposed into that population.
How can it not be introduced there when you consider the number of bisexuals?
Sure. Well, that's another point.
AIDS spread in Africa and every other nation among the general population because those nations received the WHO's smallpox vaccine. Only in America, HIV spread among homosexual males because
somehow the virus got introduced into that population.
An American doctor reported today that an AIDS sufferer he treated is apparently well after cell and bone marrow transfusions from an identical twin. Dr. Anthony Fauci cautioned that this is not a breakthrough. He called it a small but important building block of knowledge.
Yesterday, the National Institute of Allergy and Infectious Diseases that another 1,000 AIDS victims would be added to experimental programs, meaning roughly 1/3 of all victims would be involved. Here is a sample of the pro-con testimony today.
Perhaps should be clarified is what you mean by promising. Sometimes things are considered promising based on really virtually no or very flimsy types of evidence, and that's the whole purpose of these treatment evaluation units, to establish as quickly and as expeditiously as possible what is promising and what is safe and what is effective, so that we can make those as quickly publicly available in a widespread manner to as many patients as we possibly can. Probably one of the fastest pushing throughs of contract reviews and implementation that we've had, at least in my memory. A group of individuals who have access to the data so that the code of a controlled study can be broken if, in fact, certain results look to be very good or very harmful before the end of the study. And this way you don't have undue time in doing a study in which you have your answer right away, nor do you allow a study to go on further than it should when it's obvious that there's significant toxicity. There's a clinical trials coordinating group which will have access to all the data in a database so that it will be easily able to be analyzed and made available so that one would know rather quickly the data as it becomes available.
As you've been listening to the testimony from the earlier panel, professionals out there, as well as the patients, have no sense that in fact there is a ready availability of that information at this point.
Yeah. Hopefully we'll change that. No, we probably could do some more.
Why aren't we doing it?
I think one of the reasons probably would be that the limited resources.
Is that certain agents are, and we've already shown a couple with AIDS, are not safe. They make the patient worse. So if you give everyone the drug and they're all getting worse, you won't notice that unless you're comparing it with someone who's not getting it. To say, well, we're really concerned about the patients who have the disease now, which we are, in fact, quite concerned. Let's modify the scientific integrity of the study. The real shame and tragedy will be 5 years down the pike if because of that compromise, we still don't have an agent that's safe and effective because we compromised our method of testing it. That would be the real tragedy.
At last, there is some good news to report on AIDS. An experimental drug called AZT has been shown to prolong the lives of AIDS victims, they said, and it will now be made available to AIDS patients throughout the United States.
Half of the patients received a sugar pill and half received azidothymidine, AZT.
Doctor, how important is this announcement today?
It's really quite important. This has been the first time that an agent that blocks the virus which causes AIDS, the AIDS virus, has been shown to have a significant clinical effect in a carefully controlled study. So the implications of this are really quite important. Drug has shown to be effective by the study that was just terminated.
At least we are closer to a cure. Before AZT was found on the shelf at the Burroughs Wellcome Company?
We are certainly much closer to an effective treatment for this disease with this particular agent than we have been up to this time in the history of AIDS.
The AZT trials are a masterclass of data manipulation, and Fauci was complicit as overseer of AIDS research. AZT trials had to be terminated early due to the amount of deaths during the study. 95% of participants didn't finish the trial, lasting only an average of 17 weeks on AZT. Placebo and experimental groups mixed due to the smell of AZT making the pills easily distinguishable. Deaths in the AZT group were reported as placebo deaths. The FDA judged these discrepancies didn't influence the validity of the data, inviting all of the industries it regulates to join in on the lawlessness. Pharmaceutical manufacturer Burroughs Wellcome claimed 4,000 studies demonstrated the benefits of AZT, when there were 0 studies proving AZT benefits. In fact, AZT was shown to be a potential carcinogen that was more dangerous than the AIDS disease itself. AZT performed worse than placebo by making patients more susceptible to disease. Fauci, as overseer of AIDS research, refused investigation of other AIDS drug options, creating a pharmaceutical monopoly. Fauci's NIAID enrolled 1/3 of AIDS victims into AIDS drug experiments that were more harmful than the disease, leading to skewed AIDS mortality rates that influenced the government to give more tax dollars to the NIAID, part of the public health service that allegedly created the AIDS problem. By manipulating the AZT data, the dangers of AIDS drugs were concealed, leading to more deaths than if there were no pharmaceutical interventions. As the AZT news distracted the public, the Reagan administration passed the National Childhood Vaccine Injury Act of 1986, protecting vaccine manufacturers from lawsuits for vaccine-related deaths and injuries.
If you look at people who have any experience and looked at the data, overwhelmingly they will tell you that it is not spread by casual contact. And what we're seeing here in these polls with the quarantine answer, the answer with regard to casual contact or what have you, is a skepticism about that. But I don't think there is very much disagreement among experts, at least experts who are informed experts, that in fact there is not casual contact.
I know of no good researcher
anywhere in the world who disagrees with the statements that we have been making.
One of the disadvantages, the potential disadvantages, is that you don't know what particular new toxic side effect you might see if you rev up an immune system against a component that they're already infected with. So scientifically, there are pros and cons to each.
Doing trials of AZT in individuals who are not far advanced in their illness. Perhaps even more important is that we now have a commitment to have drug to do a study in individuals who are completely asymptomatic. In other words, someone who's antibody positive, has the virus, but is completely well with regard to symptoms. And the reason why it's important to do studies in those individuals is because we know that in this country there are at least 1 million and maybe 1.5 million individuals who are in that category. The FDA came out with the announcement that they're really going to be able to push drugs along much more quickly. What they've been doing with AIDS drugs is moving them along remarkably quickly, despite the criticisms about that. They've really been moving quickly.
Are you personally satisfied with the speed that these things are being done?
Personally, since I'm involved in it, I'm never satisfied with the speed. I always want it to be done quicker, and I'm constantly pushing people to the point of pushing them too much, maybe.
An agreement has been reached between the Department of Health and Human Services and the Institut Pasteur, which resolves the differences between the two over the patent rights for the AIDS antibody test kit. The two medical groups will share the patent. We're also tearing down the regulatory barriers so as to move AIDS from the pharmaceutical laboratory to the marketplace as quickly as possible. As individuals, we have a moral obligation not to endanger others. If a person has reason to believe that he or she may be a carrier, that person has a moral duty to be tested for AIDS. Human decency requires it.
It very likely came from an ancestral virus present in the monkey, probably the African green monkey from Central Africa. What the mutational events that occurred, how long that took to occur, we're not sure, but from a molecular standpoint, it looks very much like it comes from an ancestral monkey virus. Nothing has changed about AIDS. It still is not transmitted by casual contact. So the general person in the street need not worry about getting AIDS by the kinds of casual interactions that one has with individuals, be it in the workplace, in the street, or what have you. The advice, the scientific advice, the public health advice should come from the scientist, and then the power of the political process could make that move and make things happen.
The advances over the last 10 years in molecular biology have allowed scientists here at the NIH to be able to, as we call it, map the genome of the AIDS virus, being able to point out and isolate each of the genes of the virus. This is of great importance because by recombinant DNA technology, deleting different genes, we're able to pinpoint the function of the genes. Once the function of the genes is known, you can then make manipulations to interfere with the function of the virus. An understanding of the outer coating of the virus, which is coded for by this envelope gene, allows us to understand the heterogeneity which makes one virus a little bit different from another virus. Even though essentially they're the same, the differences have major implications in vaccine development.
Scientists today announced the first approved trial of an experimental AIDS vaccine on humans.
The vaccine is a protein component, the envelope or outer coating of the virus, and it's very important to emphasize that we are not injecting the virus itself into these volunteers.
That's the question many people will
There
have.
is no chance that they can get AIDS from the vaccine because the virus itself is not being injected. The outer coating or the protein envelope of the virus is being injected.
Is there any risk to these volunteers?
The risk would probably be the kind of risk that you would have from any injection of foreign protein. And then there's always the way out chance, which you'll have to inform the volunteers of developing a peculiar hypersensitivity reaction to the protein.
There's universal agreement among public health service officials that testing someone and then if they're positive, isolating them, quarantining them is totally, one, not logistically possible, and two, incompatible with the public health service component of what you're trying to do. If someone knows that there is a possible negative component to being tested or to have their sexual partner tested, you will then drive underground the very people that you're trying to bring out and test and counsel. That's a big problem. I mean, if you vaccinate someone who's not infected and you have an effective vaccine, when they get exposed, they won't be infected.
Anthony Fauci is in a race in which millions of lives worldwide hang in the balance. He is in charge of the nation's research effort against AIDS. As he runs this scientific marathon, there are many spectators, and not all of them are happy at the pace he is keeping. Doctors and scientists there, and indeed around the world, are with Fauci on an elusive trail. They are on the trail of a killer, and Finding a way to stop AIDS has become the top medical priority in a global race against time and disease. Fauci is the director of the National Institute of Allergies and Infectious Diseases and is the commanding officer in the nation's scientific war against AIDS. He and his team choose the strategy and the weapons to be used against the virus.
I don't think there's any question that the most promising treatment right now is the only drug that has been shown to be effective in an appropriately controlled trial, and that is AZT, or azidothymidine.
Last October, the NIH awarded part of an $18 million research grant to study the effects of AZT in children. Cynthia's physician, Dr. James Oleski, hopes she can participate in the trials.
We really feel strongly about the AZT, that it's the first time we're doing something positive about this disease and not just supporting the kids. So if you can see your way clear, I would recommend them going AZT.
This is the first national test of AZT on children. Dr. Oleski thinks it should have happened sooner.
And children deserve access to investigational drugs like adults do.
He is one of 59 healthy homosexual men who have been injected at the NIAID with an experimental vaccine in what was the first human test of an AIDS vaccine. Like the volunteer seen in these pictures, prior to inoculation, Lynn had the study protocol explained to him, along with the potential risks. The date was September 21st, 1987. Lynn would be the second man injected with the vaccine. The vaccine was developed by scientists at the company and at the NIAID. It uses a virus found in insects called a baculovirus. This can then be used to genetically engineer and manufacture a substance called GP160. But are the AIDS vaccine tests being conducted here moving too fast? Some scientists contend that the vaccine first should have been tested in animals before it was put into humans.
It's one of those things that you're damned if you do and you're damned if you don't. But it's very difficult to show protection in an animal model because there is no animal model that, strictly speaking, is the perfect animal model.
So in this phase 1 low-dosage test, men like Lynn are the human-animal models. Possible side effects include testing positive for HIV infection and a more virulent response should he ever develop AIDS.
Setting the pace, I think of Dr. Fauci. Probably never heard of him. He's a very fine research, top doctor at National Institute of Health, working hard doing something about research on this disease of AIDS.
He's creating a tremendous amount of anxiety in the people who are infected because they think that there's some conspiracy among scientists against them.
That AZT are effective in preventing the onset of recognizable disease, then you have enormous implications. Now, that's something that hasn't been proven yet, but I'm confident as a scientist involved in this area that that day will be coming soon, because there is one particular gene of HIV called the envelope gene, which has the capability of being extremely heterogeneous. It can differ from one isolate to another. It can differ from an isolate in San Francisco versus an isolate in New York. And we know that when you develop a vaccine, you have to have common determinants so that you elicit an immune response, so that if a person gets exposed to HIV, whatever strain or isolate that that person gets exposed to, that person will have an appropriate and adequate immune response to protect him or her against HIV. Unprecedented virus leading to an unprecedented disease. For people who have disease, AZT is readily available in a pharmacy. You can buy it.
The trial, known as ACTG Protocol 019, compares 2 doses of zidovudine, or AZT, with placebo in 2 groups of HIV-infected volunteers who have no symptoms. Recommended that the placebo arm of the study be halted for participants with fewer than 500 T4 cells, and that all participants whose T4 counts are less than 500 should be offered AZT. Because the data from this study have shown that the short-term risk of developing AIDS is negligible in asymptomatic persons with more than 500 T4 cells, the study will continue for that latter group. The whole concept of AZT resistance, the knowledge of that is really incomplete at the present time. There were 38 progressions in the placebo group and only 17 in the low-dose group and only 19 in the high-dose group. It's an estimate, and it's an estimate based on an estimate, but that's the best we can do.
After AZT was approved by the FDA based on manipulated data, ACTG Protocol 019 took the scientific fraud to the next level, manipulating data to prove that AZT could prevent onset of AIDS after failing to prove AZT could provide any treatment to AIDS patients. Protocol 019 skewed the data by only showing short-term results. 2-year and 3-year analysis from doctors not funded by Fauci showed AZT did not slow replication of HIV or prevent progression of disease. Shielding the public from the knowledge that his chosen therapeutic was doomed to fail, Fauci protected pharmaceutical manufacturers and harmed the public he was supposed to serve.
In 1987, the first glimmer of hope. Now, everybody was on a high because we now had a drug. It was short-lived because what we kind of realized but didn't admit, when you have a highly replicated RNA virus, it will mutate and it will develop resistance. And that's exactly what happened. But that didn't stop the research community.
The whole concept of AZT resistance, the knowledge of that is really incomplete at the present time. There's not a ban on fetal tissue research at all sponsored by federal funding. There is a moratorium on fetal research from induced abortions for the purposes of transplantation. Is that having impact on AIDS research? Right now, no. We can do in vitro test tube fetal tissue research. Many of us use fetal tissues for cell lines. In fact, a number of laboratories at the NIH and in NIH-funded institutions. Initial studies with AZT alone indicate that when someone is without symptoms and have modest diminution of their immune function, you could prolong the disease-free state by a finite period of time, a year and a half, or what have you. What we want to do is really prolong that, so by the middle or end of the 90s, we'll be able to say that we have AIDS from a therapeutic standpoint that's really a manageable chronic disease. This is the goal. Studies of HIV gene function have resulted in an explosion of knowledge over the past few years. Yet only after further in-depth understanding of the regulation of HIV gene function can the concept of actually manipulating viral genes and intracellular immunization become a practical reality.
Through genetic engineering, scientists recreate bits and pieces of the AIDS virus. Right now, the compound, called 8GP30, is being tested for safety on healthy volunteers at San Francisco General Hospital. Volunteers may be at some small risk for toxic side effects from 8GP30, but it won't give them AIDS. But scientists caution that chimps and humans react differently to AIDS. For one thing, chimpanzees don't get sick from AIDS, even if they have the virus.
That in the animal models, using either whole-kill vaccines, whole-kill viruses, recombinant products, that if you challenge the monkey and the SIV or the chimp with the HIV, that you can actually induce protection. We now know it's feasible. Now we've got to apply that to the human system.
Could you imagine what it would have been like if we did not have the capability of understanding how a virus such as a human retrovirus works if this virus happened to come along in the 1950s? We know now that drugs like AZT and DDI and DDC and others, it is only for a temporary period of time. We know the results now with AZT, but also they're relatively toxic. And what is the answer to a drug that is toxic because it's relatively non-specific and lasts for a brief period of time, measured in just a couple of years, because there's the emergence of resistance? Targeted drug development based on recombinant DNA technology. And as you well know, the vaccines that are in clinical trial right now are a direct reflection of biotechnological advances, namely the recombinant proteins of GP160, GP120.
The vast amount of protection of the blood supply is due to voluntary screening out of individuals.
At this point in time, there's no reason to believe there's any danger with the blood supply.
As scientists and as physicians, we are essentially against mandatory testing. I mean, if one would talk about mandatory testing in society, the easiest way to drive people away is to make something mandatory with the hidden agenda of there being something punitive about it. If you want to bring people in to counsel them, then it shouldn't be mandatory.
It's a terrible idea from a public health standpoint or any standpoint to isolate people who are HIV infected and think that you can protect the general public by putting people into forced isolation. The answer is not to sequester and quarantine people. That is a very bad public health idea, not to mention ethical and moral and a few other things.
When you're asking a drug, any drug, AZT, DDI, DDC, and now even the protease inhibitors, to do that for an extended period of time where you keep the virus suppressed, that's where it fails.
You haven't got anything really to give these people now. I mean, that you can be confident
there's certainly
beyond a certain few months or whatever it is.
That is correct.
approving a second generation of drugs called protease inhibitors, with commercial names like Inverase and Novir. These drugs attack a different part of the virus, significantly slowing a protein called protease that the virus needs in order to replicate. Last year, the NewsHour reported on a study of prostitutes in Pumwani, crowded slum just outside Kenya's capital, Nairobi. Wanjiru has remained HIV negative despite repeated exposure for years to the virus.
Thinking more and more that these women represent an instance of natural immunity to HIV.
Standard triple combination, it's anywhere between $15,000 and $20,000 if you consider the protease inhibitors plus 2 of the standard first-generation drugs. And then you add on to that the other drugs that some patients who have very suppressed immune systems need to be on to prevent the occurrence of the complicating infection. You put that all together, it becomes a very expensive proposition, usually above $20,000 a year.
It is really a molecular biological scenario where it uses its own genetic material. It then integrates itself into the chromosome of a cell. That is very unusual. There are not many viruses that do that. And as a matter of fact, retroviruses do it so well that retroviruses in a more attenuated form are the major vehicles for gene therapy. So it really is gene therapy. Unfortunately, it's destruction and not therapy. Each time the virus replicates, it has the potential and the reality for a mutation. Of course, reverse transcriptase is a very promiscuous enzyme and doesn't have a good proofreading mechanism. So it makes a lot of mistakes. Many of the mistakes makes the virus resistant to things like some of the antiviral agents that we have.
Yet while Elizabeth was able to take AZT to fight the disease, Ariel was not. As one doctor told Elizabeth, "We don't even know what dose to give her. We can't just experiment. This is a toxic drug. It could kill her." The plan the president is announcing today will see to it that no child or parent will have to endure this kind of agonizing uncertainty. It will guarantee that children get the same access to newly developed drugs as their parents.
Less than half the drugs used to help the estimated 12,000 children with HIV infection in our country have been tested for use in children, all of whom have introduced legislation that would provide additional incentives for drug manufacturers to perform the needed dosage studies in children.
It's a double vaccine. Consists of an animal virus called canary pox, which is harmless to humans, that has been changed so that it contains HIV genes. It also contains a protein called GP120 that stimulates the immune system.
You can talk about the development of new drugs by using the power of recombinant DNA technology. You could talk about the development of vaccines.
We know from studies done a few years ago that you can substantially block, not completely, but substantially, the transmission from an infected mother to the infant by treating the mother for a considerable period of time during the pregnancy and then treating the infant immediately after the pregnancy for a few weeks. Although that works, that's really not feasible for developing countries that can't afford that amount of antiviral drug.
During the 90s, Fauci, the NIH, and the FDA worked in concert to make children accessible for AIDS drug experiments. Children were given expanded access to such experiments during the Clinton administration. A 1994 experiment claimed children taking AZT reduced mother-to-child transmission of HIV. The placebo group were given AIDS drugs immediately to prevent a proper scientific comparison. 1 year later, the experiment was found to be false because AZT was ineffective in children. The experiments showing AZT prolongs short-term survival, AZT delays onset of AIDS, and AZT preventing mother-to-child transmission were all subsequently found to be fraudulently manipulated. Yet these experiments were the scientific foundation for approving AIDS drugs in pregnant women and children. Building upon the fraudulent AZT research, in 1999, an AIDS drug, nevirapine, was tested in pregnant women and children in Uganda. Nevirapine, like AZT, had a reputation as a toxic drug. The data was manipulated on every level. There was no control group in this study. Records were missing, deaths were not reported, and a systematic ignoring of adverse events. Some deaths were not attributed to the AIDS drugs, but were blamed on the economic conditions of Uganda. Even after data manipulation, 30% of infants experienced serious adverse events after 18 months of AZT or nevirapine. 38 babies died during these experiments, 16 on nevirapine, and 22 on AZT. NIH founded AIDS drugs experiments on foster children from 1985 to 2005 were exposed as violating federal regulations on human research. Less than 1/3 of foster children had monitors for these experiments. Children were put in foster care because parents refused to give their children AIDS drugs. As harmful as these unethical experiments on children were, the larger scale harm came from the fraudulent data used to progress AIDS drug research. Nevirapine was central to Fauci's $15 billion PEPFAR program to provide AIDS drugs in Africa. An NIH regulator filed complaints on the nevirapine experiments to Fauci personally. What was Fauci's response? You're fired. Further shielding Fauci from accountability for overseeing unethical experiments, his wife, Christine Grady, was appointed the head of bioethics at the NIH in 1996. Christine Grady did not view any of these experiments as unethical.
Some of my colleagues got up and essentially said, we don't really want you here. And I had to make a decision of essentially doing things which is very painful, of getting rid of some of the people that worked for me. You know, I used to joke around and say I took the old motto from The Godfather, it's nothing personal, it's strictly business.
If it pleases the court of public opinion, we shall establish Fauci's 21st century position on certain subjects before the coronavirus pandemic. Exhibit A, masks.
There is no need to panic, nor any need to do anything different. People ask, should I be wearing a mask? No, not at all. But at this point in time, we do not need masks in the United States in the normal intercourse that we have in society, walking around, going to work, going to school. We do not need masks. So for someone to try and sell someone a mask and say you really do need a mask, that is not in accordance with the public health recommendations. To go to Japan, you would not be wearing a mask because for a number of reasons, we don't have a situation here in the United States which would warrant a mask, as I've mentioned to several callers.
There's a photo here of, I guess, an airline attendant for a Thai Airlines in Thailand, I guess, with 2 bottles of disinfectant and a mask. Does this have any effect?
Again, there's a wide variability in the compulsiveness of people. If I saw somebody walking down the street in front of the Capitol here with a mask and a disinfectant sprayer, I would think that they were a little bit on the fringe.
People who feel for their personal protection they have to wear these masks. One has to change those barriers several times for them to be effective, both in the transmission and the reception of any communicable disease.
Gloves and masks, and you're absolutely correct. If not used correctly, it really doesn't make sense to use them at all, particularly in understanding the right seal, etc.
Somebody's sitting next to me and they're coughing. Should I say, look, I'm sorry, but I'm susceptible to your thing, and just move away? Do you ever have this problem?
I do.
What do you put a mask on? You put like a gauze thing on, or?
No, I don't. But
wearing a mask.
No.
You do that. If I can see they're ready to sneeze or cough, walk away.
You avoid all the paranoid aspects and do something positive.
Exhibit B, mandates.
Yeah, and they're also afraid that there's going to be forced inoculation at some point. There could be some emergency declared, and the government has plans for forcing people to take.
There will not be any mandated or compulsory vaccinations vis-a-vis influenza. That's for sure. So take that off the table.
Whenever you make a decision about any intervention that you're going to allow yourself to undergo, be it a drug or a vaccine, you've got to balance the risk of what you're going to do with the benefit that you're going to get from it. You recommend it, but you explain the risk-benefit as opposed to making it official policy. Since smallpox has some rare but nonetheless potentially very serious toxic side effects, if you're one of those people who have this strange myocarditis associated with it, that we would not globally vaccinate the entire country. And by the way, the country would not have accepted being vaccinated. We knew that. I mean, it was sort of like a fail-safe. And I said, Mr. Vice President, by the way, even when you're offering it to the first responders, many of them didn't want to take it. So this idea about kind of saying everybody should take it, it didn't make any sense. Historically, pandemics do occur, and responding to the pandemic after the fact is generally not effective.
Exhibit C, communicating to the public as a public health official.
Is to be very transparent as public health officials and to not be afraid of saying you don't know the answer. And you don't know the answer and you think it's better to guess than to say you don't know. That's a huge mistake. And people have done that. The right thing is to disappoint them. You know, I don't know the answer to this. Otherwise, your credibility is gone pretty quickly.
I don't really remember anything that I really screwed up badly to the point where it was like, oh my God, what did I do?
In the beginning of an outbreak, hardly anybody knows anything, no matter how smart they are.
Exhibit D, relationship with the pharmaceutical industry as a government fundraiser.
With Dr. Fauci here, actually, the study from the NIH, from his division, the headline, study finds pill greatly lowers risk of AIDS, drug already sold. How significant a finding, and what is the finding?
Well, as I said and quoted in that article, it is a huge finding. It is really very significant. Well, the private sector is doing very, very well. Bill and Melinda Gates Foundation, the Clinton Foundation has done a phenomenal job. The NIH, since the beginning, has spent $45 billion on HIV research.
One of them is to regulatory flexibility. And I have to say, I really want to tip my hat to the FDA because over the last several years, they have worked with us right from the very beginning. Right now, whenever we do anything, we get them involved right from the very beginning to make sure we're right on the right track. I was going to take this sleepy field of infectious diseases, which was like the 6th or 7th largest institute at NIH with a budget that was like $300 million at the time. And I was going to make it something bigger because, and particularly, I was going to use it as the bully pulpit to get attention to HIV/AIDS. I started off with a budget of about $300 million. My budget is now close to $5 billion. So if I were a Wall Street mogul, I would get some kind of a golden parachute or something there, but not. But you know, the relationship with George H.W. Bush was really an interesting relationship because he wanted very much for me to be the director of NIH. I didn't want to do that because I didn't want to get out of the AIDS business. We used to only vaccinate people who were at high risk. Now it's vaccinate everybody. I always joke with my co-institute directors that probably sooner or later every disease is going to turn out to be related to an infectious disease. Just kidding. I just want more money.
Exhibit E, the HIV/AIDS hypothesis.
Versions of what we call the quasi-species or the different components. That it isn't one virus that's uniform. It's what we call a quasi-species, which means there are multiple subtle changes. It exists almost like in a swarm of viruses as opposed to one identical virus that you have millions of copies of. There are millions of copies of different types of modifications of the virus.
Natural immunity.
But she's had the flu for 14 days. Should she get a flu shot?
Well, no. If she got the flu for 14 days, she's as protected as anybody can be because the best vaccination is to get infected yourself. If she really has the flu, she definitely doesn't need a flu vaccine. If she really has the flu.
She should not get it again
No,
this
she
year?
doesn't need it because it's the most potent vaccination is getting infected yourself.
Which disease is more dangerous, influenza or coronavirus?
Just the word flu. Often people say, well, I'm sick today or I'm out to work, I have the flu. Well, you probably didn't have the flu. You probably had a rhinovirus or an adenovirus or a coronavirus. When you have the flu, you know you have the flu.
Exhibit F, prediction of the pandemic.
Is that there is no question that there will be a challenge, the coming administration, in the arena of infectious diseases, but also there will be a surprise outbreak. What about things that we're not even thinking about? It is not going to go away. So the thing we're extraordinarily confident about is that we are going to see this in the next few years. Thank you.
There's this whole new strategy called pandemic preparedness that we didn't have years ago. It was always wait around for something to happen and then respond as quickly as you can. Now, a lot of stuff is preemptive, particularly in developing easily adaptable vaccine platforms.
Exhibit G, gain-of-function research. Gain-of-function is research that improves the ability of a virus to cause disease. Gain-of-function research is gene editing of a virus to produce a desired function. The virus will gain a function such as an animal virus jumping species into humans. Gain-of-function research on SARS coronavirus has been funded by the NIH since 2014. Gain-of-function scientists working with RNA viruses that mutate and can adapt to hosts are a biosafety risk. In October 2012, Fauci proposed a doomsday scenario where a gain-of-function scientist became infected with the virus they were manipulating, causing an outbreak and triggering a pandemic. Despite these risks, Fauci was clear about his view of funding gain-of-function experiments months later.
A considerable amount of the activity that goes on in this area from a research standpoint comes from the NIH and NIAID. As you know, we're part of the Department of Health and Human Services, as is the Centers for Disease Control and Prevention, who also have a considerable amount of contributions, both from a public health surveillance as well as from a research standpoint, in the topic for today, which is gain-of-function research on highly pathogenic avian influenza H5N1. Was intensive study of host adaptation, transmissibility of influenza viruses, pathogenesis, and virulence. And integral to that study has always been the issue of gain-of-function research, not only for influenza, but essentially for all infectious diseases research. Now, there are a few ways to look at gain-of-function research. There's the naturally occurring mutation which naturally give gain of function. Does this mutation make something more transmissible, more pathogenic, or adapt to host better? Or is to actually create gain of function by making mutations. But the bottom line is that gain and loss of function research is critical to understanding disease pathogenesis, antimicrobial resistance, and host responses, as well as to developing better techniques of surveillance, vaccines, and therapeutics. There was studies done by two NIH, NIAID-funded investigators, Ron Fauci and Yoshi Kawaoka, in which H5N1, a strain from Indonesia and a strain from Vietnam, were altered in a gain of function, either by direct mutation or by reassortment. And by passage in ferrets, the mammal model for this virus for humans, a development of aerosol transmissibility in a mammal, which this particular virus did not have. We at NIAID, being the major funders of most but not all of these people, we obviously were connected to that because they wanted to know, since you're our major funders, what kind of research will you fund? Questions have come up about the concern of the danger of people that you fund. NIAID, NIH, certainly CDC, only funds and conducts gain-of-function research for researchers who are highly trained. The concern was that the products or information that were generated by these experiments might be used by others in a way that could harm society. There's disagreements as to the scientific and/or public health value of these experiments, but I believe the people who feel that they shouldn't be conducted are in the minority, because even the most concerned members of NSABB felt that the experiments should be done, but the distribution of the knowledge should be restricted.
If you completely ban all gain-of-function research, then you're going to interfere with some of the important things we need to do.
Exhibit GP120, glycoprotein 120. A glycoprotein on the HIV envelope that specifically binds to the CD4 T helper cell to enter the host cell. The 1972 WHO bulletin requested a virus that selectively inhibits the T cell to prolong disease. GP120 is the part of that requested virus, HIV, that selectively inhibits the T cells. If I wanted to pick out one part of HIV that would do the most damage to the immune system, I would pick out GP120. That's exactly what Fauci did.
GP120, glycoprotein 120, it's the coat protein of the AIDS virus. About half the people with AIDS get AIDS-related dementia, hippocampal damage, memory loss, tremendous cognitive impairment, and GP120 appears to be the key peptide in killing the hippocampal neurons, a very complicated indirect route. And what my lab has been seeing is every bad thing that GP120 does to a neuron, glucocorticoids make worse. And that one becomes really disturbing, not just because people with AIDS are under stress, but people with AIDS come down with pneumocystis pneumonia, and for the severe cases, the only treatment is to give people the highest doses of glucocorticoids that are ever used in clinical medicine.
Such a disagreement about whether or not the NIH, NIAID would fund large-scale studies of recombinant GP120 proteins. Both trials failed. That by injecting the outer covering or the envelope, the GP160, the GP140, the GP120, any of that into an individual induced an immune response, but the immune response was not protective. We started that after like 84, 85, 86. The HIV envelope is naturally unstable. It really is a humbling experience because everybody, all the smart people in vaccinology and immunology were saying, you got to make an antibody that's a neutralizing antibody against a very constant region of the envelope. Well, HIV is an RNA virus, and like other RNA viruses, it is probably the king or the queen of the mutational RNA virus. RNA viruses mutate a lot. The important mutations in HIV are that, one, it evades the immune system. It's one of the 3 or 4 reasons why the immune system is not particularly effective, so it's not good for the natural immune response. Unlike any other vaccine, the body doesn't really like to make a protective immune response against HIV. It's one of the few viruses where the natural response to infection is not what you want.
The origin of the coronavirus pandemic derives from gain-of-function research funded and approved by Anthony Fauci and the NIH and NIAID. Gain-of-function experiments that Fauci and others warned could cause a pandemic. In retrospect, the U.S. government should have listened to James Clapper in 2016, who labeled gene editing as a weapon of mass destruction. But instead, they listened to Anthony Fauci, who said that gene editing was necessary for expedited vaccine development. Since 2014, NIH and NIAID funded gain-of-function experiments at the Wuhan Institute of Virology and the University of North Carolina. Peter Daszak of EcoHealth, Ralph Barrick of UNC, and Wuhan's Shi Zhengli have over a decade experience working together to manipulate coronaviruses to infect humans in a way that would evade therapeutics and vaccines, creating the optimal virus to cause a pandemic. Although there was a gain-of-function funding pause in 2014, these experiments were approved by the NIH. Despite NIH funding dozens of gain-of-function experiments at the Wuhan Institute of Virology, the origins of the coronavirus pandemic could be traced back to one specific gain-of-function experiment between the Wuhan Institute of Virology and the University of North Carolina from 2014 to 2019. Understanding the risk of bat coronavirus emergence, funded by the NIH, NIAID, and the DoD to combat weapons of mass destruction. Bats in a Yunnan cave system carried SARS coronaviruses with all the unique genetic elements of the SARS coronavirus outbreak virus. Naturally, the scientists chose to sequence 12 novel SARS coronaviruses from this cave system, constructing a chimeric virus using a SARS backbone and a coronavirus spike protein adapted to efficiently replicate in human cells and infect humans via airway cells, enabling the cross-species airborne transmission of SARS coronavirus from other mammals to humans. NIH investigators trusted the Wuhan Institute of Virology with handling the dangerous specimens for spike protein sequencing. Despite the repeated history of safety violations at the Wuhan Institute of Virology from 2018 to 2019, warning of urgent problems the institute was facing in July of 2019. 1 month after the NIH experiment finished a renewal phase of the project, by November of 2019, officials at the Wuhan Institute of Virology warned of severe consequences that could result from safety dangers. Ralph Barrick believed the SARS coronaviruses he was manipulating would not infect human cells. This belief prevented gain-of-function classification on these experiments. Barrick, Daszak, and Shi were dead wrong. These experiments should have been classified as gain-of-function research. When the defendant, Mr. Fauci, had the chance to review this research, he deemed it not risky enough to fall under the moratorium. This research has been disputed as the origins of the pandemic because it would implicate the virus as being man-made by NIH-funded scientists. The fact check of this paper supports the natural origin of COVID-19, despite the fact that this study reports Chinese people post-SARS avoided bats at a level that would prevent a naturally occurring pandemic. This may be disputed as the origin of the pandemic, but there is no disputing that this research from 2014 to 2019 laid the foundation for manipulating SARS coronaviruses to infect humans while evading therapeutics and vaccines, which would create the optimal environment for causing a pandemic. In the attempt to combat weapons of mass destruction, the NIH funded gain-of-function research that created a viral weapon of mass destruction. Bioweapon research, funded by Anthony Fauci, is the origin of COVID-19.
Coronavirus was enhanced in a lab. The National Institutes of Health acknowledged that it funded research of a virus that was studied at the Wuhan Institute of Virology.
For years, the National Institutes of Health provided grant money to the EcoHealth Alliance Research Group, which conducted experiments with bat coronaviruses in Wuhan, China.
January 31st, 2020, Indian scientists published a paper revealing COVID-19 had 4 separate inserts of HIV, 3 of which are glycoprotein 120. GP120 is the portion of HIV that specifically targets the T helper cell to enter the host. COVID-19 spike glycoprotein contains 3 insertions of GP120, which do not exist in any other coronaviruses, making it impossible to claim that COVID-19 evolved naturally. HIV proteins GP120 and GAG are critical for the viruses to identify and latch on to their host cells and for viral assembly. GP120 enhances the affinity for cross-species transmission by increasing the range of host cells that the virus can infect. HIV's GP120 enabled the construction of a pandemic-level bat SARS coronavirus spike protein during NIH gain-of-function experiments. The Wuhan Institute of Virology and University of North Carolina have been pseudotyping HIV with SARS coronavirus since 2015. Pseudotyping a virus is the process of producing viruses in combination with foreign viral envelope proteins, meaning SARS coronaviruses were produced in combination with a foreign HIV envelope protein, GP120. Spike proteins are the critical target for vaccine development of coronaviruses. GP120 is the portion of HIV that makes producing an HIV vaccine an impossible task. Fauci, owning 4 separate patents on GP120, understood the significance of the Indian paper. GP120 within the spike protein would expose the unnatural origins and prevent the production of a safe and effective COVID-19 vaccine.
It then integrates itself into the chromosome of the cell. That is very unusual. There are not many viruses that do that. Retroviruses do it so well.
A FOIA request exposed Fauci's emails during the first few months of the pandemic, revealing a desperate attempt to cover up the origins of COVID-19 and the findings of the Indian GP120 paper. 5:27 p.m., January 31st, 2020. A reporter's email questions the NIH about findings of the Indian paper suggesting COVID-19 has 4 inserts of HIV. 5 hours later, Anthony Fauci, Jeremy Farrar of AZT manufacturer Burroughs Wellcome, and Christian Anderson discuss COVID-19's genome. Christian Anderson asked Fauci about the unusual features of the virus because the GP120 would make COVID-19 engineered. Christian also noted the inconsistencies of the evolutionary theory of the origins of COVID-19.
There was a phone call in late January of 2020 from Jeremy Farrar, Christian Anderson, who piped me in on a 3-way call saying that they looked at the virus and there was some concern about the molecular configuration or makeup of the virus that made them think there was a possibility that there could have been a manipulation of the virus.
That night, as January turned to February, Fauci emailed the number 2 at NIAID, demanding Hugh read a Barrick and Shih gain-of-function paper. Fauci most likely sent the 2015 Barrick Shih Nature article because the paper reveals the unnatural origins of COVID-19 and the use of HIV at the Wuhan Institute of Virology. Hours after that meeting, Fauci sends an email with an attachment titled Coronavirus Sequence Comparison. On the Sunday morning of February 2nd, after Fauci's numerous meetings with the most powerful people in science, the GP120 paper was magically retracted. The Indian GP120 paper was retracted not because of the facts, but because the information of HIV being in COVID-19 would lead to conspiracy theories. A conspiracy means two or more people planning to commit a crime. Therefore, the Indian paper was retracted because the paper caused people to realize that two or more scientists planned to commit crimes against humanity. February 4th, 2 a.m., an anonymous scientist emails Dr. Fauci warning of the implications of the GP120 inserts inside COVID-19. Hours later, Christian Anderson and gain-of-function scientists Peter Daszak and Ralph Barrick discuss constructing a letter with the purpose of disputing conspiracy theories of engineering COVID-19, stating that the virus evolved naturally because if the virus was engineered nefariously, the scientists would have used a SARS backbone and reverse genetic systems. Ironically, the Wuhan gain-of-function experiments did use a SARS backbone and reverse genetics. And the experiments claimed the virus could not have evolved naturally due to a lack of Chinese interaction with bats. Later that day, Fauci forwards an article stating the retraction of the Indian GP120 paper was a good moment for science. As per our recent conversation, suggesting Fauci's involvement in the retraction. February 13th, Fauci informed the CDC director that 15 scientists will be determining the evolutionary origin of COVID-19, ignoring the lab leak theory. March 2020, the proximal origins of COVID-19 paper was released, with the goal of ending the debate on the origins of COVID-19. April 18th, Peter Daszak emails Fauci thanking him for publicly supporting the natural origin theory of COVID-19. Daszak thanks Fauci as the personal investigator of R01, the gain-of-function studies in Wuhan from 2014 to 2019, further implicating that those studies were in fact the origin of COVID-19.
Biological Warfare Center in Wuhan, and that the coronavirus escaped from that.
I've heard these conspiracy theories, and like all conspiracy theories, they're just conspiracy theories.
Luc Montagnier is the French discoverer of the HIV virus. His words have been translated into English. We've come to the conclusion that there was a manipulation of this virus. There's a model that is evidently the classic virus, and that was a model that came from the bat. But to this model were added some sequences, some from HIV, the AIDS virus. It's not natural. It's the work of professionals. It's work of molecular biologists. Very meticulous work. Someone tried to make an HIV vaccine, so they took some small sequences of the virus and put them inside the bigger sequence of the coronavirus. That means there is a part of HIV inside the virus? Exactly. The genetic code of the virus is like a long ribbon of RNA. Just like DNA, but it's RNA. And some small sequences of HIV were attached to this ribbon. These sequences are small, but they still mean something. They have the ability to modify antigenic sites. If you wanted to create a vaccine, you could modify the protein that is exposed for the vaccine by a small sequence that came from another virus. But are you sure of it? Because it was thought to be of human origin at first, but in the end it was debunked by most of the scientific community. There is certainly an attempt to suppress the truth. We are not the first ones. A group of researchers from India, highly reputable, published the same findings, but they were forced to withdraw them. These traces of HIV cannot be the result of a natural crossover between animal and human species? No. It can only be man-made? Exactly. Luc Montagnier, April 17, 2020. On February 4th, 2020, the Secretary of HHS declared a public health emergency, allowing liability immunity for any activities related to medical countermeasures against COVID-19, or any mutating virus therefrom. The public health emergency invoked Section 564, providing the FDA the authority to designate unapproved medical products as emergency use authorized to fight COVID-19. Emergency use authorizations have stipulations. The disease, COVID-19, must be proven to cause serious or life-threatening disease. The products to treat COVID-19 must be effective in treating or preventing COVID-19. Or these products can treat conditions caused by unapproved products that were emergency use authorized. The potential benefits of COVID-19 treatments must outweigh the risk of the disease itself. Most importantly, emergency use authorizations cannot be designated if there are adequate, approved, and available alternatives to treat COVID-19. In addition to the public health emergency and the EUA, President Trump declared a national emergency on March 13th, granting $42 billion for the nationwide response to a virus that had an estimated 98 to 99% survival rate. On March 16th, the Trump administration announced 15 days to slow the spread, a 45-day nationwide shutdown that led to 3 million Americans losing their jobs.
When the guidance and the guidelines and the suggestions were put out officially from the government, it was said as a 15-day period. That does not mean it's only going to be 15 days. It means at the end of 15 days, we'll reevaluate and see if what we've done have had any noticeable impact and is it worth going on. I would project personally, though it's always dangerous to make these kinds of projections, that we will go longer than 2 weeks.
What was the most crucial decision you had to make during the pandemic, and what was the critical thought process that took you through it?
I recommended to the president that we shut the country down. And that was a very difficult decision because I knew it would have serious economic consequences, which it did.
On March 24th, 2020, the FDA issued the first of 87 EUAs for mechanical ventilators. Mechanical ventilators became the emergency standard of care for COVID-19. March 30th, 2020, a Seattle study showed 9 of the 11 COVID-19 deaths were after mechanical ventilation. Less than a week after the EUA, evidence showed mechanical ventilators were a riskier treatment for COVID-19 than the disease itself. Further exacerbating COVID-19 death and case totals, hospitals were reimbursed for treating COVID-19 patients, cultivating an environment within hospitals of developing a lucrative distinction between dying of COVID and dying with COVID. If COVID-19 was suspected, it was acceptable to report COVID-19 on a death certificate as probable or presumed. Death certificates began to report COVID-19 even when tests were negative, or even when no test was given.
We've seen this in other disease processes too. Early in the HIV epidemic, somebody may have a heart attack but also have HIV. The hospital would prefer the DRG for HIV because there's greater reimbursement. So I do think there's some reality to that. When it comes to death reporting though, ultimately it's how the physician defines it in the death certificate. When it comes to hospital reimbursement issues for individuals that get discharged, there could be some play in that for sure.
Very painful early years of HIV, AIDS, when people talk about conspiracy theories. You will always have conspiracy theories when you have very challenging public health crises. They are nothing but distractions. I would just hope we just put those conspiracy stuff and let somebody write a book about it later on, but not now.
Thanks to the CARES Act, hospitals were reimbursed $13,000 for treating someone with COVID and $40,000 for 4 days of ventilator support before a 20% bonus. Hospitals in less populous states received $300,000 per COVID case, while the most populous states received $12,000 per case. These policies were designed to create a self-fulfilling prophecy, justifying the public health emergency by incentivizing hospitals to inflate COVID-19 case and death totals. The ventilator EUA justifiably should have been revoked. Instead, up to 25% of COVID-19 inpatients had been treated with ventilators or intubation during the first few months of 2020. While publicly promoting ventilators, Fauci privately emailed in May of 2020 that mechanical ventilation harmed recovery in COVID patients.
we very, very readily would put people on mechanical ventilation when we found out through clinical experience it might have been better just to make sure we position them properly in the prone or supine position and not necessarily intubate somebody so readily, which might have actually caused more harm than good. We learned that as we got more experience.
On April 16th, pharmaceutical company Gilead submitted an unapproved product, remdesivir, for emergency use authorization to treat COVID-19 patients. A curious choice considering in 2019, remdesivir killed 50% of the patients in Ebola trials. The remdesivir trials were sponsored by Gilead, the NIH and NIAID, and the U.S. Army. The data submitted was meager at best, with studies showing more deaths in the remdesivir group due to toxicity in the kidneys. Remdesivir was developed through partnership of Gilead, NIAID, and UNC Chapel Hill in the Ralph Baric Lab. Ralph Baric's gain-of-function research involved developing therapeutics for viruses he manipulated, including therapeutics for SARS coronavirus. Ralph Baric described remdesivir as a game-changer for treating COVID-19. It was none other than Fauci himself who revealed the results of the remdesivir trials to the public.
A trial that the National Institute of Allergy and Infectious Diseases, which is the institute I direct, sponsored, called the Adaptive Covirus Disease Treatment Trial, or ACCT1, was started in February 21st, randomized placebo-controlled trial, comparing the Gilead drug remdesivir with a placebo. The Data and Safety Monitoring Board on Monday afternoon contacted me on April 27th, first on Friday the week before, and then again on April 27th, and notified the study team that remdesivir has a clear-cut, significant positive effect, diminishing the time to recovery. 31% improvement, less deaths in the remdesivir group, 8% versus 11% in the placebo group. It has not yet reached statistical significance, but the data needs to be further analyzed. Whenever you have clear-cut evidence that a drug works, you have an ethical obligation to immediately let the people who are in the placebo group know so that they could have access. And all of the other trials that are taking place now have a new standard of care. So we would have normally waited several days until the data gets further, dot the I and cross the T. But the data are not going to change. Some of the numbers may change a little, but the conclusion will not change. When I was looking at this data with our team the other night, it was reminiscent of 34 years ago in 1986 when we were struggling for drugs for HIV. And we had nothing. And we did the first randomized placebo-controlled trial with AZT. This will be the standard of care.
Fauci has compared this to when they first found HIV drugs. He's saying this will be the standard of care. This drug could get FDA emergency use authorization immediately based on these results.
Dr. Anthony Fauci, the face of America's response to the coronavirus. The FDA is expected to grant emergency usage for this so that it could be put into practice right away. What do you know about that? How soon do you expect that?
It's going to be really quickly. I was speaking with the commissioner of the FDA yesterday evening, last night, but I would project that we're going to be seeing that reasonably soon.
Fauci ordained remdesivir the standard of care before the FDA on April 29th. April 30th, Fauci states the FDA will approve remdesivir. Luckily for Fauci, he has regular phone calls with the head of the FDA, so he can predict the FDA's future. The very next day, May 1st, the FDA authorizes remdesivir. Fauci declaring remdesivir the standard of care for COVID-19 was reminiscent of Fauci decreeing AZT the standard of care for AIDS. By making a drug that is more harmful than the disease the standard of care, Fauci altered the public's perception of the harm of COVID-19. In one statement saying remdesivir's data had not yet reached statistical significance, yet the next statement Fauci was bragging about remdesivir's clear-cut evidence, further manipulating the data by placing the placebo group onto remdesivir, repeating Fauci's pattern since AZT. Fauci stating that remdesivir's data will not change and the conclusion will not change is not the scientific method. But there was a method to Fauci's madness. By making remdesivir the standard of care and mechanical ventilation the standard of emergency care, the medical community was mandating medical malpractice, leading to more deaths than the disease would have caused, which should have invalidated the emergency use authorization. Remdesivir treatment costs $3,000 per patient. Making remdesivir the standard of care echoes Fauci's decision-making with AZT, prioritizing the most expensive toxic treatment available, while stigmatizing affordable generic drugs with much less toxicity.
Or hydroxychloroquine, which is a drug that's been approved for decades. Very cheap.
Hydroxychloroquine was also authorized by the FDA on March 28th. Hydroxychloroquine is part of a class of drugs called zinc ionophores. Zinc ionophores taken with zinc were known to inhibit SARS coronavirus infection since 2010. Zinc ionophores, such as hydroxychloroquine, quercetin, EGCG, are drugs that when taken with zinc reduce coronavirus binding and replication. Ivermectin is also a drug that when taken with zinc achieves similar results to zinc ionophores treating COVID-19.
Initial studies didn't really use zinc with it. Had a long conversation with a doctor earlier in the week, and he said, yes, as long as zinc is there, it really definitely does work. Without it, it's minimally effective. Would you like to comment on that?
When I do see a randomized placebo-controlled trial that looks at any aspect of hydroxychloroquine, either early study, middle study, or late, if that randomized placebo-controlled trial shows efficacy, I would be the first one to admit it and to promote it. I don't have any horse in the game one way or the other. I just look at the data.
A randomized placebo-controlled trial of hydroxychloroquine emerged months later. Fauci ignored these results while promoting flawed studies that merely showed a zinc ionophore such as hydroxychloroquine is not going to function without zinc. Fauci's bias in examining the data led him to favor his horses in the game, Ralph Baric and Gilead, who received over $160 million in funding to study remdesivir from the NIH since 2009. Fauci's analysis contributed to a perverse financial incentive for hospitals to continue to select expensive remdesivir over cheap hydroxychloroquine. If Fauci made zinc ionophores the standard of care for COVID-19 rather than remdesivir, millions of lives and billions of dollars could have been saved. Fauci understood this intimately. More so, Fauci understood that if zinc ionophores became the standard of care, then that would have led to approved available alternative treatments for COVID-19. Zinc ionophores would have ended the public health emergency and therefore terminated the authority for emergency use authorizations. Fauci made remdesivir the standard of care not to extend the life of those who took the drug, but to extend the life of the emergency use authorizations. The medical community collectively was in a race against time to take advantage of the temporary liability immunity. In 1 year, the FDA granted over 600 EUAs for previously unapproved products. Fauci knew without the EUA and the temporary liability immunity, the FDA could not have authorized their most infamous unapproved product, the COVID-19 vaccine.
The administration has confirmed that it has a program called Operation Warp Speed, the goal to speed the timeline for a vaccine to develop hundreds of millions of doses to be ready by January. Do you feel that's in the realm of possibility?
Yeah, I do, Savannah. I mean, I'm obviously part of the team that's involved in that. On January the 9th, the Chinese put on a public database the sequence. As soon as we got the sequence of the virus from the Chinese, we pulled it out of the public database and stuck the gene into a vaccine platform and worked on it literally within a day of when it came out. On the 10th, we had a meeting with my team that said, we're going to take that sequence, we're going to partner with a company, Moderna, and we're going to maybe 3 or 4 days later meet and get the vaccine starting to be made.
Fauci and his team began development of the COVID-19 vaccine before they determined the origins of COVID-19.
So then you publish the sequence, and anybody in any lab can pull the sequence out of the gene that specifically codes for the spike protein. So you don't have to touch the virus. You go in silico, in a computer, you pull out the gene, and you stick it into this messenger RNA. So there are multiple platforms. So mRNA is a platform. highly adaptable, extraordinarily promising approach to vaccines where you don't ever even need to get the virus in your hand. You can just get a gene sequence, plug it into this messenger RNA and inject it into a person, and you get the protein expressed and you have a vaccine.
mRNA expressing the sequence of COVID-19 spike protein is not harmless, considering the insertions in the sequence of COVID-19. The COVID-19 spike protein contains sequences of GP120, the portion of HIV that destroys your immune system while incorporating itself into the host DNA. A vaccine expressing this GP120 inserted spike protein would therefore enhance and prolong disease instead of providing protection.
Now, the purpose of messenger RNA in your body is to code for all the different proteins that your body makes. So now you're going to take an artificially made RNA, you're going to stick this particular sequence in, and then you inject it into the body. It goes into a cell and it starts pumping out protein. So the body sees the protein and says, I think that's the virus because it's a spike protein, but it isn't the virus. It's a harmless protein that you made very quickly. With messenger RNA, RNA is the molecular means of coding for proteins. So if I want to vaccinate you, Mark, with a component of the COVID-19 virus, the SARS-CoV-2, the important component is that spike protein. Well, that particular spike protein is the thing you want the body to make an immune response against.
Viruses binding with suboptimal antibodies enhance entry into host cells and accelerated replication within the host, a phenomenon called antibody-dependent enhancement. Antibodies do not bind to HIV, specifically because of GP120. Surface proteins of HIV, like GP120, mutate rapidly and change shape continuously. GP120 is the portion of HIV that helps HIV evade the immune system and gain entry into host cells. People have developed natural immunity to HIV, but no scientist in human history has created vaccinated immunity for HIV. A COVID-19 vaccination forces antibodies to make an immune response against the spike protein of COVID-19. Since the COVID-19 spike protein contains sequences of GP120, antibodies would be suboptimal in their immune response, enhancing entry and accelerating replication of COVID-19 within vaccinated hosts, creating vaccine-induced antibody-dependent enhancement.
To make sure that a vaccine actually doesn't enhance disease, there's another element to safety. And that is if you vaccinate someone and they make an antibody response and then they get exposed and infected, does the response that you induce actually enhance the infection and make it worse? And the only way you'll know that is if you do an extended study, not in a normal volunteer who has no risk of infection, but in people who are out there in a risk situation. This would not be the first time, if it happened, that a vaccine that looked good in initial safety actually made people worse. There was the history of the respiratory syncytial virus vaccine in children, which paradoxically made the children worse. One of the HIV vaccines that we tested several years ago actually made individuals more likely to get infected. So you can't just go out there and give it unless you feel that in the field, when someone is getting infected and exposed, being vaccinated doesn't make them worse. That's why you got to do a trial. Does the vaccine make you worse? And there are diseases in which you vaccinate someone, they get infected with what you're trying to protect them with, and you actually enhance the infection.
So that the immune system doesn't run away with itself. When it does, as a matter of fact, that's how you get autoimmune disease.
Out of 44,000 participants in the Pfizer COVID vaccine trials, only 170 cases of COVID were observed. 44,000 people may have participated, but only 170 participants' data mattered. By dividing the 162 placebo cases by the total 170 cases, Pfizer arrived at the conclusion that the COVID vaccine had a 95% efficacy. There were 0 deaths related to COVID-19 during the trials and less than a fraction of a % chance of catching COVID-19. Pfizer's data invalidated the concept that COVID-19 was a life-threatening illness with pandemic potential.
DNA is inherent in your own nucleus cell. Sticking in anything foreign will ultimately get clear. Messenger RNA is the messenger. It comes from the DNA to the RNA to the protein. Sticking an mRNA into you has absolutely nothing to do with your own DNA or your own RNA. It's going to perform its function and then it's going to be degraded and it's gone. It doesn't have any imprint on any genetic material of your own.
GP120 enters a host cell such as an antibody, then integrates itself into the host genome by reverse transcriptase, meaning even though the mRNA may be temporary, the effects of the spike protein expressed by mRNA would alter your DNA. As the great Anthony Fauci once said,
whenever you make a decision about any intervention that you're going to allow yourself to undergo, be it a drug or a vaccine, you've got to balance the risk of what you're going to do with the benefit that you're going to get from it.
The proposed benefits of a COVID vaccine would be potentially protecting yourself against a virus with far less than a 1% chance of infection and death. Consider the risks of mRNA expressing spike proteins containing inserts of GP120. GP120 would integrate with your cells and alter your DNA, harm your immune system, ultimately causing antibody-dependent enhancement. The benefits do not balance. Because the risk did not match the benefits, the utmost authority in medicine had to resort to lying about the benefits to convince the public to take the COVID-19 vaccine.
What do you think is the best argument to convince those people that taking the vaccine during that time frame is the right decision for their and their family's health?
Well, because as long as you're susceptible, you're part of the problem, not part of the solution. When you're protected, you're another person the virus can't impact. Whereas if you're vulnerable, even if you don't get a lot of symptoms, the fact that you've been infected means you are inadvertently propagating the outbreak. So if you want to be part of the solution, get vaccinated and say, I'm not going to be one of the people that's going to be a stepping stone for the virus to go to somebody else. I'm going to be a dead end to the virus. So rather than getting discouraged, which is an understandable emotion to a terrible ordeal that we've all been through, hang in there. The end is in sight. And as vaccines kick in, we're going to start seeing a dramatic change. So my word of encouragement is that let's all hang in there together. We are going to get through this, guaranteed. The risk is extremely low of getting infected, of getting sick, or of transmitting it to anybody else. Full stop. We want something, ultimately, that prevents you from getting infected so that you don't spread it to someone else. That would be an important advance.
And if you vaccinate someone who's not infected and you have an effective vaccine, when they get exposed, they won't be infected.
Fauci inflated the risk of COVID-19 and inflated the benefits of the COVID-19 vaccine. Because if people honestly understood the data, that COVID-19 had a less than 1% risk of infection and death, and that the vaccine had more risks than benefits, the public's desire to get a COVID vaccine would be permanently deflated. After spending 2 years guilting the public into thinking the vaccine would stop the virus and therefore end the economic pain of the pandemic, Fauci admitted COVID vaccines do not prevent infection or transmission.
If people want to get it, they can get it, and hopefully everybody would want to get it. I would like to see the overwhelming majority of the country vaccinated before we get to the end of the second quarter, because I would like to see children, adults, everyone, so that when we get into the fall season, the children could feel really safe at going back to school. The teachers can feel safe that they're not going to get infected. We can get back to the economy being robust. Restaurants can open to full capacity. That's what I'd like to see. But you're not going to see it, Mark, unless the overwhelming majority of people get vaccinated. So in that sense, I would like to see the reluctant people get vaccinated sooner rather than later. If they want to wait a month or so, that's okay. That might be in accordance with the pace of being able to implement. But I don't want them to wait 6 to 8 to 9 months. I think they should do it within that period of the first 2 quarters of 2021. If you really want to be free of the threat of COVID-19, this is a global problem with a global solution, which means we must be able, as a global community, to vaccinate the entire world, to make sure that enough vaccine is manufactured to the tune of billions and billions of doses so that we can do with COVID-19 what we did with smallpox, to make sure that we eliminate this scourge from the entire world.
Fauci held the economy hostage, stating children and teachers could not feel safe going back to school, and businesses could not open to full capacity until the vast majority of the world became vaccinated, under the false pretense that the COVID-19 vaccine could prevent infection.
And take a look at waning immunity against infection with Janssen, with Moderna, and with Pfizer-BioNTech. As you go from month to month, the immunity clearly wanes. Declines from 87.9% to 48.1%, so we know we need boosters.
Vaccinated immunity rapidly diminished, in mere months waning under 50% efficacy. Vaccines under 50% efficacy violate the standards of the FDA, WHO, and the COVID-19 EUA. In less than a year, all COVID vaccines lack supporting data to warrant their EUAs.
I doubt that the federal government will be the main mover of a vaccine passport concept. You could foresee how an independent entity might say, well, we can't be dealing with you unless we know you're vaccinated, but it's not going to be mandated from the federal government.
President Biden would essentially require 2/3 of American workers to either get vaccinated or face weekly testing. The Department of Labor will draft new rules requiring that for all businesses with 100 workers or more. Additionally, most federal employees will now have to be vaccinated or face possible disciplinary action. It sounds as if President Biden is growing exasperated with people who are not vaccinated. Is he?
Yes, he is, and I think that was very well manifested and expressed in his speech today. We really do need to get more people vaccinated, and what he said is, I think, a good roadway to getting there. That's going to, involve in total over 100 million people. That is what we should be doing. I mean, we've tried everything we can to get people vaccinated. We have the solution within our grasp that we are going to implement that. And if that means more mandates, so be it. Science is the reason why you need to get vaccinated. So this is, in fact, putting science first. If you listen to the science overwhelmingly indicates that you should get vaccinated. So anything that the president does to see that we do get vaccinated is following the science. He's using the power of persuasion in his office as president to do that. And it was very clear from the wording of that that's exactly what he was doing. Enough is enough. We've got to get people vaccinated. We have within our grasp the capability and the tools to do it.
After stating that the federal government would not be involved in a vaccine passport system, 100 million people were affected by yet another Fauci lie. Because the COVID-19 vaccine cannot prevent disease and infection, the federal government cannot justify mandating vaccines. But that did not stop the Biden administration and Fauci. Utilizing the power of persuasion by withholding access to their livelihoods and preventing children from going to school until they got vaccinated, as the chief medical advisor on COVID-19 to President Biden said.
And if that means more mandates, so be it. As we get into the fall, for all of us who will have waning immunity, but I've been vaccinated and boosted, and certainly over a period of months, it is very likely that my immune protection will diminish to the point of needing yet again another booster.
The vaccines rapidly wane, failing to protect against infection and transmission. Fauci continued to advise doubling down on a failed vaccination strategy of getting boosted.
Now we have BA.5, which clearly, because of its ability to evade immune responses, the protection that's given to you against BA.5 wanes and diminishes pretty rapidly over a period of several months.
If you have not received a shot in 2022, how much has your immunity waned?
considerably. I mean, the thing that is important to note is that immunity against infection wanes pretty quickly and it goes way, way down. But it's slipping where it was up to 90, 80, then it goes down to 70, 75, 65, and 50. Then you're really in a situation where you really do need a boost.
A lot of people who got vaccinated got COVID anyway, and a lot of people who got vaccinated transmitted the disease to other people as well. Do you have any regrets about the salesmanship used to convince people to get vaccinated? In other words, did you oversell them? Did you give people the sense that if they get vaccinated, they're sort of in the clear, when in fact, quite clearly, that has not been the case?
And you had this quote that stood out to me. You said, show me a school that I shut down. Show me a factory that I shut down. Never. I never did. I gave a public health recommendation that echoed the CDC's recommendation, and people made a decision based on that.
We likely are moving towards a path with a vaccination cadence similar to that of the annual influenza vaccine, with annual updated COVID-19 shots matched to the currently circulating strains for most of the population.
Anthony Fauci funded gain-of-function research that created viruses that could cause a pandemic. Viruses that were designed to evade the immune response, therapeutics, and vaccines. Anthony Fauci, in response to the mess he created, was instrumental in developing and mandating a COVID-19 vaccine that failed to prevent infection. This same vaccine did not even last more than 2 years before becoming out of date. These vaccines not only failed to protect the vaccinated, but eroded their immune systems and made them more susceptible to further infections, leading to the vaccinated quickly becoming the majority of the COVID-19 deaths. Fauci promoted that the COVID-19 vaccine would eradicate COVID-19. Now, Fauci proposes a perpetual reliance upon annual COVID-19 boosters. Annual COVID-19 boosters would continue to erode the immune systems of the vaccinated, prolonging and enhancing disease within the vaccinated. Instead of eradicating COVID-19, the COVID-19 vaccine trapped the vaccinated in a never-ending series of vaccinations. The COVID-19 vaccine did not end the threat of COVID-19, but the COVID-19 vaccine should lead to the end of the threat of Anthony Fauci by revoking Fauci's medical license.
Despite Fauci's lengthy history of transgressions as a public health official, his greatest legal peril comes from lying to Congress under oath. Perjury.
Gain-of-function research, as you know, is juicing up naturally occurring animal viruses to infect humans.
Gain-of-function research on highly pathogenic avian influenza H5N1 cause a reported almost 60% mortality in humans.
Dr. Ralph Barrick, a virologist in the U.S., has been collaborating with Dr. Shi Zhengli of the Wuhan Virology Institute. Doctors Barrick and Shi worked together to insert bat virus spike protein into the backbone of the deadly SARS virus, and then use this man-made supervirus to infect human airway cells. Dr. Fauci, do you still support funding of the NIH funding of the lab in Wuhan?
We obviously were connected to that because they wanted to know, since you're our major funders, what kind of research will you fund?
The NIH has not ever and does not now fund gain-of-function research in the Wuhan Institute.
Coronavirus was enhanced in a lab. The National Institutes of Health acknowledged that it funded research of a virus that was studied at the Wuhan Institute of Virology.
The NIH and NIAID categorically has not funded gain-of-function research to be conducted in the Wuhan Institute.
For years, the National Institutes of Health provided grant money to the EcoHealth Alliance Research Group, which conducted experiments with bat coronaviruses in Wuhan, China.
So do you still support sending money to the Wuhan Virology Institute?
We do not send money now to Wuhan.
A considerable amount of the activity that goes on in this area from a research standpoint comes from the NIH and NIAID.
The NIH and NIAID did not fund gain-of-function research.
We at NIAID, being the major funders of most but not all of these people.
We did, under your tutelage, we were sending it through EcoHealth It was a sub-agency and a sub-grant. Do you support the money from NIH that was going to the Wuhan Institute?
Let me explain to you why that was done.
Does this mutation make something more transmissible, more pathogenic, or adapt to host better?
You do support it in the U.S. We have 11 labs doing it, and you have allowed it here. We have a committee to do it, but the committee has granted every exemption.
Dr. Barrett does not doing gain-of-function research, and if it is, it's according to the guidelines.
That the experiments should be done, but the distribution of the knowledge should be restricted.
And if you look at the grant and you look at the progress reports, it is not gain-of-function.
Is the gain-of-function research in studies that increase predominantly the transmissibility?
You are saying things that are not correct. No matter how many times
you're parsing
you say
words.
it,
There
it
was
didn't happen.
research.
The reason we are here today in this room, and we're not in this room discussing so many of the other gain-of-function research that we do,
we have not funded gain-of-function research.
But the bottom line is that gain and loss of function research is critical.
Government scientists like yourself who favor gain-of-function research.
I don't favor gain-of-function research.
If you completely ban all gain-of-function research, then you're going to interfere with some of the important things we need to do.
17 signed a paper that called it conspiracy theory, the idea that the virus could have originated in the lab. You think words like conspiracy theory should be in a scientific paper?
Senator, I never used that word when I was referring to it.
Biological warfare center in Wuhan, and that the coronavirus escaped from that.
I've heard these conspiracy theories, and like all conspiracy theories, Newt, they're just conspiracy theories.
Can you sit here and unequivocally say the viral studies that NIH funded could not be indirectly or directly related to this final COVID-19 virus?
Yeah, looking at these experiments that were done that we funded, there would not be that possibility. A hybrid virus of a mouse virus that was adapted to a mouse, that anyone that knows anything about virology would realize that that is not something that would infect a human, much less be pathogenic and transmissible.
Fauci claiming a mouse virus could not infect humans is patently false.
In the study of the murine and other animal retroviruses and the ability to examine not only the structural genes of those viruses, but also the regulatory genes.
Whether the viruses come from monkeys, bats, cattle, mice, or pangolins does not matter. They are all mammals. Cross-species transmission of mammalian retroviruses into humans has been documented since the 70s. In 1971, Stuart Aronson made the pioneering discovery that a mouse retrovirus could adapt to human tissue and replicate within human cells. The 1972 WHO Bulletin specifically requests the study of such mouse retroviruses in humans to prolong disease in humans. Gain-of-function study on any mammalian virus has the ability to transmit vertically into humans. When Ralph Barrick's mammalian virus gained the function of airborne transmission into humans, Barrick said, "I don't think you can ignore that." Yet Fauci ignored the warnings as he promoted gain-of-function research in laboratories across the world, creating new non-natural risks that provided no benefits. Gene editing, gene therapy, and gain-of-function research were presented as opportunities to advance the health of humanity, when in reality, gene editing and gain-of-function research represent the greatest threat to civilization that the human race has ever known. The foremost proponent and progressor of gain-of-function research is none other than Dr. Anthony Fauci. Mr. Fauci even ignored his own warnings of gain-of-function research causing a pandemic. The defendant, Mr. Fauci, repeatedly lied under oath in regards to gain-of-function because the risk of perjury did not outweigh the benefits of his lies. These lies were designed to grant Fauci the immunity that his COVID vaccines could never provide. As the leader of a scientific cover-up, these lies prevented the public from fully understanding Fauci's involvement in the origins of COVID-19. Why would the U.S. government and WHO scientists across the world want to create a virus to prolong disease in humans? As the director of the National Institute of Allergies and Infectious Diseases, Anthony Fauci understood that an infectious disease, simultaneously destroying and evading the immune system, would provide perpetual problems, requiring permanent pharmaceutical solutions. By manufacturing crises and exacerbating them, Fauci was able to spread fear faster than the disease. Capitalizing on that fear, Fauci coerced an exponentially increasing NIAID budget.
Anthony Fauci established a consistent pattern of behavior as a public health official. 40 years of violating the Hippocratic Oath by protecting pharmaceutical producers while harming the public Fauci was supposed to serve. Rather than preventing disease, Fauci's tenure at the NIAID will be defined by a constant stream of infectious diseases with failed responses. Fauci's approved treatments for these diseases were consistently more dangerous than the disease.
Fauci oversaw and funded the research for AZT, nevirapine, remdesivir, and the COVID-19 vaccine, without unethical experiments manipulating the data to hide the risks and inflate the benefits. Fauci wouldn't have developed a single treatment for AIDS and COVID-19, but by spreading fear, compelling the government to declare public health emergencies, Fauci bypassed regulations and standards that would have prevented approval.
Any scientific dissenters who dared question Fauci's data manipulation were blacklisted, labeled as quacks, and some lost their medical licenses. Censoring the evidence shielded Fauci in the tunnel vision of his agenda, declaring himself immune from scientific judgment.
The medical community relies upon a moral authority granted by the public, assuming that the doctor will treat the patient without violating the Hippocratic Oath. Fauci's actions have damaged the public's trust in the medical community more than any individual in scientific history. By providing documentary evidence, we illustrated a full context of Fauci's career. The trial of Anthony Fauci grants the jury in the court of public opinion immune to the system of Fauci's revisionist history. Today, it is not just Fauci on trial, but all of the scientific research Fauci promoted. Gene editing, gain-of-function research, and gene therapy stand before the judgment of this court. Manipulating viruses to infect humans, and utilizing retroviruses to edit genes. Funding research that resulted in death and no health benefits. Gene editing, gain-of-function research, and gene therapy have all led to the unconsented experimentation of the human race. Fauci's decisions will continue to alter the DNA of the American public and the world long after he is gone. It is a hard thing for an experimental scientist to accept, but it has become all too evident that Anthony Fauci stands guilty of ignoring the dangers in knowing what should not be known.
I show you some representative papers giving you an idea of the kinds of things I was interested in. The suppression of the immune response in humans by immunosuppressive therapies like glucocorticoids.
So the WHO has this R&D blueprint which aims to reduce the time between when you declare a public health emergency and you have a vaccine ready. So what they've done is that they've named a number of diseases to be urgently addressed under the R&D blueprint, CEPI, which is the Coalition for Epidemic Preparedness and Innovations, which are working with a number of partners, including us, to develop vaccines against priority pathogens, to develop platforms, to perfect platforms that are easily interdigitated with whatever outbreak you have. So here are some of the vaccine platform technologies.
A lot of other disciplines benefited from the study of HIV, even our understanding of the immune system that was by an experiment of nature. In this case, the experiment was the infection of the human species with this virus has allowed us to be able to delineate much more precisely many of those circuits of regulation of the immune system.